As the last few people trickle in, I think we're going to go ahead and start so we can honor our time together. Hello, I'm Robin Axel Adams. I am the manager of the Fairbanks Center for Medical Ethics. Welcome to our last lecture of this lecture season that we have. We will be taking the summer off, but we will be back in September. And I already know the fall lineup, and I'm really excited to be able to share that with you soon. So today's lecture is being co-sponsored by the IU Health Risk Retention Group. We are grateful for their providing lunch for us today and for helping to have things organized today. This lecture is being recorded, so if you would like to watch it later, you can always go to our website, fcme.org, and we will find that for you. And then you also have people that are watching around the state, and so we welcome all of you around the state who are watching this today, and thank you for continuing your ethics education with us here today. As a reminder to silence all of your devices, and then if you need to return a call, please do so by leaving the auditorium. And Dr. Scott has no financial conflict that she needs to report. So this lecture today is in the last of our series this year of IU Health's Enterprise Goals. In January, we kicked off this series and have been talking about healthcare disparities, about smoking cessation, about behavioral health, and now here our final series around infant mortality. And so we're so excited to wrap up this series today with having Dr. Emily Scott with us. She is a pediatric hospitalist at Riley Hospital for Children and the current medical director of the Well Newborn Unit at IU Health Methodist Hospital. She is currently the president-elect of the Indiana chapter of the American Academy of Pediatrics and a March of Dimes Advocacy Fellow. She is active in state and local efforts to increase infant mortality rates in Indiana, and we're so excited to have her share her knowledge with us. So welcome, Dr. Scott.
Just to clarify, I want to decrease infant mortality. So I'm so excited to see so many people here today to talk about this really important topic. We're going to start by talking about Indiana's high infant mortality rate and really diving into the existing black-white disparity. We're going to further our discussion with talk about structural racism and how implicit bias may play a role in disparities in infant mortality rates. And then finish up by talking about some programs that are working right here in Indiana on disparities in infant mortality and working to promote health equity in the state. So about 5 years ago, I became medical director of Well Newborn Care right here at IU Health Methodist Hospital. While I was aware at the time that Indiana had a significantly higher infant mortality rate than the national average, I was not aware that the disparities exist right here in Marion County between black and white infants. And over the past 5 years, I have been struck by how unfair that is. It is not right that any baby born in this hospital has a better chance for survival than another. So today, I want to share with you what I have learned about racial disparities in infant mortality. I know I do not have all the answers, and my talk today may raise more questions for all of us to explore together. However, I want to open a conversation about why so many more black babies are dying in Indiana, and most importantly, what we can all do together to promote health equity for our tiniest Hoosiers. So let's start with some really basic definitions. What is infant mortality? It is defined simply as the death of a baby before his or her first birthday. Infant mortality rates do not include babies who die before they're born, such as from miscarriages or stillbirth. And when we talk about infant mortality rates, what we're talking about when we use a number is the number of infants who die per 1,000 live births. We know the most common causes of infant mortality include prematurity, so babies being born before 37 weeks gestation, babies being born low birth weight, or less than 5.5 pounds, congenital malformations or birth defects, and then a number of babies die due to sudden unexpected infant death, which is sleep-related deaths typically that occur at home due to accidental suffocation and strangulation in bed, or SIDS. And then there's a percentage of babies that die from injuries and assaults as well. So before we dive deep into Indiana's numbers, we're going to start by looking at infant mortality in the U.S. in general. Despite spending more money per capita on healthcare than any other country in the world, the U.S. infant mortality rate is higher compared to other developed nations and has dropped from 6th to 26th over the past several decades. In fact, the U.S. infant mortality rate right now is about 2.5 times higher than it is in Finland and Japan. Primarily, the high U.S. infant mortality rate is driven by preterm births and our disproportionately high Black infant mortality rate. This graph from the CDC shows that the infant mortality rate in the U.S. has been roughly stagnant for the past decade, with significant differences based on baby's race and ethnicity. So the black line in the center is the overall infant mortality rate, and you can see that non-Hispanic white infants and Asian and Pacific Island infants have a lower than the national average of infant mortality. But our American Indian and Alaska Native babies, as well as our non-Hispanic Black babies, have a much higher infant mortality than the national average. Throughout the U.S., states vary widely in their infant mortality rates, with Indiana ranked 44th in the country and consistently in the bottom 10 states in the U.S. for infant mortality. As you can see, we're in company with a lot of our neighbors in the Midwest, South Central, and Southeastern United States. On this graph, the darker colors are the colors with higher rates of infant mortality, with Mississippi right here being the highest. Likewise, there's wide variation in the Black infant mortality rate in the U.S., with the highest rates again being seen in our fellow Midwestern states in the South Central and Southeastern U.S. The white states on the map are states where a rate can't be calculated due to a very small number of Black infant deaths each year. In 1850, when babies died so often that their parents didn't name them before their first birthday, the United States began keeping records of infant mortality by race. In 1850, a Black infant was 1.6 times more likely to die than a white infant. This was 15 years before the end of slavery. Through the 1950s, that difference remained about the same. So in 1950, Black infants were about 1.5 times more likely to die than a white infant in the first year of life. However, by 1988, Black infants were dying at double the rate of white infants, and that disparity has continued to rise. And while we've seen an overall decline in infant mortality since the 1980s, the Black infant mortality rate in 2015 just reached the level of the white infant mortality rate in the 1980s. We know that Black women are still 50% more likely to deliver a premature baby, and that Black infants who are born premature have nearly a full 4-fold increased rate of death than white infants. So let's turn specifically to Indiana. Governor Holcomb has made reducing Indiana's infant mortality rate a priority for his administration, with the goal of implementing new programs to help more babies celebrate their first birthdays. In fact, Governor Holcomb has set a goal for Indiana to have the lowest infant mortality rate in the Midwest by 2024. We are right now the highest in the Midwest. And so we have a really long way to go. In 2017, 602 babies in Indiana died. That is more than 8 school buses filled to capacity. That is more than 50 babies a month, 12 babies every week. And by the time you wake up tomorrow morning, another baby will have died. The U.S. infant mortality rate reached the Healthy People 2020 goal set by the Department of Health and Human Services already. However, the infant mortality rate for Indiana has remained higher than the national average. It has remained more or less stable for the past decade, sometimes making small improvements, only to lose gains the following year. So on this graph, you can see the blue is Indiana's rate, the green is the U.S. rate, and then the red is the Healthy People 2020 goal. Causes of infant mortality in Indiana look similar to what they do nationally. About half of our babies die due to perinatal risks. So these are typically babies who are born preterm or at low birth weight. 18% of babies die due to congenital defects, and about 1 out of every 6 infant deaths are due to sudden unexpected infant death, largely driven by unsafe sleep practices. And like the US, infant mortality rates vary widely throughout the state. Many of our higher population counties, like Marion, Lake, and Allen counties, have higher infant mortality rates than the state average, while our more suburban areas, like as you can see in this graph, Hamilton and Hendricks County in the Indianapolis metro region, have lower infant mortality rates than the state average. And like the US, we have dramatic disparities between our Black and white infant death rates. In 2017, a Black infant was 2.6 times more likely to die than a white infant in Indiana. Do you guys remember what it was in 1850? 1.5, yeah, exactly. So when you look at our disparity gap, now it's actually wider in 2017 than it was in 2010. The Black infant mortality rate in Indiana is currently higher than the infant mortality rate in Syria. And we don't have to look far to find zip codes in Indiana with Black infant mortality rates on par with Guatemala, Indonesia, and Azerbaijan, with infant mortality rates for Black infants as high as 23.4 per 1,000 live births. In fact, in some neighborhoods in Lake County, people report it is unusual not to personally know someone who has lost an infant in the past several years. Black and white infants also die due to different causes, with over half of African American babies dying due to perinatal risks like prematurity or low birth weight, and another quarter dying due to sudden unexpected infant death. And in fact, for most markers impacting infant mortality, we see disparities. So for the next several slides, what you guys are looking at is the blue is the Indiana state average for infant mortality rate, the red is for white infants, and the green is for Black infants. And so this is for low birth weight babies. This is for preterm babies. And then this is for babies dying due to sudden unexpected infant death. So what we have to ask ourselves is why? Why is the Black infant mortality rate higher than the white infant mortality rate? And the first question that people often ask is it genetic? Is there something that is predisposing our African American babies to be dying at a higher rate? Could there be a gene, an infant mortality gene, a prematurity gene that we need to look for? And people used to think this might be the case. I'm going to describe a couple studies. This is a really elegant study that was designed by some neonatologists out of Chicago, Drs. Collins and Dr. David. And they compared birth weights as a surrogate for prematurity for 3 groups of women delivering in Illinois. They looked at US-born white mothers, US-born Black mothers, and African-born Black mothers. And so if disparities were due to race or genetic predisposition, a genetic factor due to, what would you expect to see? Which groups would you expect to have similar birth weights? Yeah, so the US-born Black mothers and the African-born Black mothers, you would expect their infants to have the same prevalence of low birth weight or prematurity, a surrogate for prematurity, right? But what they actually saw was that the birth weights of babies born to US-born white mothers and African-born Black mothers were similar, and the infants born to US-born Black mothers were smaller. A few years later, they replicated this study in Black Caribbean immigrants and in the US and found similar results. So the question they asked was, why would US-born Black women have smaller babies than African-born Black women? It can't be due to genetics. And then they went further and published another study a couple years later, and they looked at the birth weights of grandchildren born to immigrants to the US. So we know that in non-immigrant populations, birth weight tends to rise in subsequent generations. So like, I should be bigger than my mom, my daughter should be bigger than me. And so what Dr. Collins and Dr. David actually found was this. while the grandchildren of white European women actually weighed more than their mothers had at birth, which is what you typically would expect to see in a non-immigrant population, the daughters of African and Caribbean immigrants who grew up in the U.S. went on to have babies that were smaller than their mothers had been at birth. So their theory was that it took just one generation for American black-white disparity to manifest. So now researchers really don't think that the black-white disparity in infant mortality is related to the genetics of race. In 2007, Dr. David and Dr. Collins published an even more thorough examination of race and infant mortality in the American Journal of Public Health, again dispelling the notion that some sort of gene would predispose black women to preterm or low birth weight births. David stated his hypothesis in very blunt terms. He said, for black women, something about growing up in America seems to be bad for your baby's birth weight. So what could it be? So after the genetic basis was dispelled, researchers began turning their attention to risk factors for infant mortality. Things like smoking, poor or limited prenatal care, poor maternal health status at the time of conception and pregnancy was obesity, chronic health conditions, maternal depression, anxiety, substance use, short interval pregnancy or women having babies too close together. Was it unsafe sleep practices? And so this led to a lot of blaming the mother because a lot of people thought, even doctors and public health experts, that infant mortality was affecting primarily only poor, less educated women. And so there was a lot of blaming of women. Was she smoking or drinking? Was she doing drugs? Was she not going to her prenatal visits? Was she skipping prenatal vitamins? Did she not eat well enough? Was she not being careful? But a study of more than 1,000 women in New York and Chicago found that black women actually were less likely to drink and smoke during their pregnancy, and that even when they had access to good prenatal care, their babies were often born small. And in fact, controlling for some maternal risk factors associated with infant mortality does not eliminate the gap between black and white infant mortality rate within these risk groups. In fact, the black-white differential is actually greater for infants born to moms with fewer risk factors than for those moms who are in a higher risk group. And so what else do we know? Well, we know that conventional risk factors have a more pronounced negative effect on black infant outcomes. And we also know that protective factors for pregnant women do not provide the same benefits for black women as they do for white women. It makes sense for us to think that women who are of lower socioeconomic status are more likely to have a preterm birth. After all, they have diminished access to healthcare sometimes, diminished access to quality food and housing, and they may have increased poverty-related stressors. However, why do black women living in poverty have a higher prevalence of low birth weight deliveries than white women living in the same circumstances? With white women of low socioeconomic status, deliver low birth weight infants about 8% of the time, while black women of lower socioeconomic status deliver low birth weight infants about 11% of the time. So even with the same economic status, black women are delivering preterm or low birth weight infants more often. And then we have to ask, why does an increase in income for white women protect them from having a low birth weight baby when an increase in income does not have the same effect for black mothers? So when you look at this study, they actually show that the difference between low and high socioeconomic status white women, it decreases their risk of having a low birth weight baby as they are of higher socioeconomic status. But for black mothers, it actually didn't make a difference. And then researchers further examined this, and they found something I think that was even a little bit more interesting. They looked at the prevalence of low birth weight deliveries in black and white women of high and low socioeconomic status, but also looked at the neighborhoods that the women lived in. And what they found was that the lowest prevalence of low birth weight deliveries occurred for women of higher socioeconomic status living in a neighborhood with people similar to them. For example, the prevalence of low birth weight was lowest among higher socioeconomic status black women living in a higher socioeconomic status black neighborhood. And it was almost exactly the same as the infant mortality rate for higher socioeconomic status white women living in a higher socioeconomic status white neighborhood. But the highest highest low birth weight prevalence was actually among higher socioeconomic status Black women living in a higher socioeconomic status white neighborhood. Just really interesting why that would happen. So researchers hypothesize that maybe racial isolation may explain the lack of protection that higher income provides under other circumstances. When we look at maternal age and impact on infant mortality rate, we generally think that preterm birth and infant mortality are highest in adolescent mothers and in women delivering over 40, and that women are relatively protected from bad outcomes by having babies in their 20s and early 30s. But when we look at this graph from the CDC, we see that in fact maternal age is protective, but really only for white mothers. So the white women are seen in the lighter pink or lighter purple, depending on what it looks like out there, and you do see that protection. So the infant mortality rate declines, to like the lowest points between 25 and 34, and then starts to rise again. But for Black mothers, we do not see that same dip in infant mortality rate based on mother's age at pregnancy. We often also think that increasing educational attainment is protective against infant mortality. We assume that by graduating from college, you would have a better chance of having a healthy baby than you would if you didn't finish high school. This study from the 1990s looked at infant mortality rate just among college-educated families from white and Black. And in this population, disparities continue to exist. The infant mortality rate was 1.8 times higher for Black college-educated families than for white college-educated families. And the rate of low birth weight was more than twice as high for Black mothers than for white mothers. So in this article that came out in the New England Journal back in the 90s, the authors hypothesized that persistently higher rate of prematurity among infants born to Black college-educated parents could be due to a number of factors, including insufficient access to healthcare services, some substandard healthcare from physicians and other healthcare personnel, or standard medical care that does not adequately address the needs of pregnant Black women. And this graph from the Brookings Institute shows that indeed increasing educational attainment is protective against infant mortality for white women. However, you do not see that same classic trend for Black mothers. What we do see is that, in fact, an African-American mom who has an advanced professional degree has a higher infant mortality rate, higher chance of having her baby die than a white mother who has not finished 8th grade. So the question is why? Dr. Arlene Geronimus is a professor in the Department of Health Behavior and Health Education at the University of Michigan School of Public Health, and she concluded that persistent racial differences in health may be influenced by the stress of living in a race-conscious society. These effects may be felt particularly for Black women because of the double jeopardy of gender and racial discrimination. And Dr. Geronimus went on to study this further, and looking at data, questionnaires, and blood tests to measure the effects of stress on the body, she went ahead and controlled for income and education, but still found that African-American women had the highest measurements of stress-associated body chemicals and their cumulative effect on body systems, higher than that for both white women and for Black men. So what some people have hypothesized is, could this be a factor leading to preterm birth and infant mortality? And we have to think about these factors in the context of the structural racism that exists in our society. Structural racism is a system in which public policies, institutional practices, and norms work to reinforce and perpetuate historic racial group inequity. Structural racism identifies dimensions of our history that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. This is not policymakers intentionally discriminating, but it is people not changing long-standing practices that continue to reinforce the status quo. So a couple of examples of this just to make it a little bit more clear. One example is school funding based on property taxes. So in poor communities, the funding for schools is lower than it is in affluent communities. That's how school funding works, based on property taxes. And it's not as somebody is intentionally saying in 2019, I'm going to give this school that serves primarily a lower income Black neighborhood $100,000, but I'm going to give this school that serves a primarily affluent white neighborhood $500,000. But that is kind of what structural racism is. It's not changing what has been the long-standing policy in our country. Another example is residential segregation. It is no longer legal to discriminate in housing, but many people of color continue to be tracked into neighborhoods with limited opportunities for health based on poor quality schools, housing, poor employment prospects, and exposure to physical and social health hazards like pollution and violence. And then we have to consider structural racism in conjunction with implicit bias. Implicit biases are involuntary and unintentional attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. They cause us to have feelings about other people based on their race, ethnicity, age, or appearance. These biases begin at an early age and develop over a lifetime. So most of us in the room are healthcare professionals, and you may be thinking, I don't have implicit bias. I'm a doctor. I went into medicine to help people. But what we do know is that we are helpers. We are altruistic. We're noble. But we do have very similar rates of implicit bias as the general population. And how does that play into everything? And there are a lot of studies to support this in healthcare. So I'm a pediatrician, so I can pick on pediatricians. We are usually thought to be the nicest of all doctors. We like kids, we're fun, everyone, we get along with everybody. But this paper published just within the past 2 years actually looked at implicit bias among pediatric residents, so doctors in training, and they used the Harvard Implicit Bias Survey. And what they saw was actually significant degrees of pro-white bias that was actually more skewed for children than it was for adults, which is really interesting. And implicit bias absolutely affects our healthcare delivery. You could give multiple talks on all the studies that have been done that talk about how implicit bias affects healthcare delivery. This, again, is just one from pediatrics that looks at the administration of opioid analgesia for children with appendicitis and shows that white children receive more aggressive pain management than Black children. And this is absolutely affecting our infant mortality crisis in America. To quote Linda Villarosa in the New York Times, for Black women in America, an inescapable atmosphere of societal and systemic racism can create a kind of toxic physiologic stress, resulting in conditions, including hypertension and preeclampsia, that lead directly to higher rates of infant and maternal death. And that societal racism is further expressed in a pervasive, long-standing racial bias in healthcare, including the dismissal of legitimate concerns and symptoms that can help explain poor birth outcomes, even in the case of Black women with the most advantage. I know a lot of you guys have heard Serena Williams' story around the delivery of her child, and I think that is a really good example, the way she kind of talks about that. So we have to recognize that we're operating in a society with structural racism and implicit bias, and this is something that we absolutely have to address if we are going to make any impact on the disparities in our infant mortality rate. We must strive for health equity, in which everyone has a fair and just opportunity to be healthy, regardless of their race, socioeconomic status, and background. And striving for equity means that we must remove obstacles to health, such as poverty and discrimination, including lack of access to good jobs, fair pay, quality education and housing, safe environments, and healthcare. And we have to be mindful of the difference between equality and equity. Equality means that we give everybody the exact same thing, or in this case, the same step stool. That sounds fair. We want to give everybody the same thing in theory, but that means that these little kids on the side still can't reach their apple. And so equity actually is what is fair, and that's giving people what they need to be healthy and successful, or in this case, giving people different levels of step stools so they can reach their own apple. Health disparities adversely impact groups of people who have systematically experienced greater social and economic obstacles to health based on their racial group or characteristics historically linked to discrimination or exclusion. we must reduce and eliminate health disparities to achieve health equity. And how should we move towards health equity? Well, it requires approaches that know and build upon existing strengths and assets in affected groups. Approaches should address not only overt discrimination, but implicit bias and discriminatory efforts of structures and policies created by historical injustices, even when the conscious intent to discriminate no longer exists. So we're going to finish up just by talking about some current programs in Indiana that are working to address infant mortality from all different areas. And then I recognize so many people in the room who are also doing good work, and so I would invite you guys at the end maybe to share some of the stuff you're doing as well that I didn't mention. I didn't know how much time I'd have left, so this is definitely not a comprehensive list. And so a couple things that are being done at the level of the State House. One is the Perinatal Navigators program. So this was a bill passed by both sides of the State House to establish perinatal navigators with the goal of enrolling women with Medicaid in areas at high risk for infant mortality, working with them to access care and get appropriate services and interventions according to their level of risk. This will address barriers to care and help with wraparound services, and hopefully help have moms have healthier pregnancies and healthier babies. Governor Holcomb has also signed new legislation to make Indiana the third state to extend Medicaid coverage for doulas, making them more accessible to our higher risk populations for infant and maternal mortality. Are there any doulas here today? Not today, okay. So doulas provide physical and emotional assistance for mothers throughout their pregnancy and through the first 6 weeks of their baby's life, although some programs push this out further. Doulas provide all kinds of support, from labor coaching and breastfeeding support, through just general care of the mother and providing education. Pregnant women receiving support from doulas are less likely to have a C-section delivery. And in one recent study out of New York State, families that were supported by a doula had a decreased rate of low birth weight and preterm deliveries. So the hope is that by increasing accessibility to doulas, which are typically only accessible by upper middle class people, this will actually reduce Indiana's high rates of infant and maternal mortality in the populations that need it the most. As a side note, while this bill was passed and signed by Governor Holcomb, lawmakers actually stripped funding for the doula Medicaid expansion out of the budget right before the end of the session last week. So step in the right direction, but we will need some funding probably to make this work, because I think the key is to really recruit people from the neighborhoods that we want to serve to be doulas, because we want our doulas to understand and have our mamas feel comfortable bringing their concerns as well. We're expanding the DOSE program in Indiana. So DOSE is direct on-scene education, and it's an innovative attempt at eliminating sleep-related infant deaths due to suffocation, strangulation, or positional asphyxiation by using first responders to identify and remove hazards while delivering education on scene during emergency and non-emergency 911 calls. So if they attend a call and they find an expectant mother or baby, they will actually do an environmental check of the infant sleeping environment, provide education, and then resources as needed. So lots of people in Indiana have already been trained in DOSE. Indianapolis Fire Department, IMPD, Indianapolis EMS already have personnel trained in DOSE as well. We also have brought programs like Nurse Family Partnership to Indiana. So NFP is a model that's existed for 4 decades, but it's just been in Indiana within the past 10 years. And this program pairs mothers pregnant with their first child with a registered nurse for home visits during pregnancy and through the first years of their baby's life, with the goal of improving birth outcomes and developmental success of the children. And they've had a lot of great success. Over 50% of the clients NFP serves here in Indiana are Black. 90% of their babies are born at healthy weight, and 91% of them are born at full term. They've also been very successful in helping moms stop smoking during their pregnancy, initiate and sustain breastfeeding, and increasing the uptake of immunizations, which is now more important than ever. We also know that breastfeeding is crucial to improving the health status of our moms and babies. Breastfeeding cuts a baby's risk of sudden unexpected infant death in half, keeps the baby healthier in the first year of life and as he grows, and prolongs interpregnancy intervals, which impacts the health of moms' future pregnancies as well. The Baby-Friendly Hospital Initiative supports exclusive breastfeeding and delivering hospitals, which impacts continued breastfeeding through the first year of life. You are currently sitting in the first baby-friendly hospital in Indiana, which was designated in 2002. And in the past, 17 years now, there's been an explosion of baby-friendly hospitals throughout the state, but particularly in the past couple years, there are now over 20 baby-friendly hospitals in Indiana. And one graph that I'm excited to show you from Indiana is that there's been a lot of success in decreasing the disparity of breastfeeding rates between our white and our Black moms. Black mothers have traditionally breastfed at much lower rates than white women, in part due to the painful history of breastfeeding during slavery. However, programs like Baby-Friendly Hospitals, the Indiana Black Breastfeeding Coalition, which does amazing work, have been really successful in working together with community partners and decreasing the disparity gap in breastfeeding over the past decade. And we're continuing to think outside the box. So what kind of a doctor do most women of childbearing age see more than any other kind? You would think an OB. They probably actually see a pediatrician, right? So they see the pediatrician or the pediatric provider for their own children way more often than they see their own healthcare provider. Those of you guys who have little kids know that to be the case. There's like 8 visits in the first year of life. So can we engage pediatricians to perform some basic screening for moms during their child's child checks to help ensure that mom's next pregnancy has a healthy outcome? Can we help her stop smoking? Can we screen her for depression? And if she is depressed, make sure she gets into resources and care. Can we educate her on the importance of spacing her births at least 18 months between her last delivery and her next pregnancy, and make sure that she's taking folic acid? So this is the concept between March of Dimes Implicit Interconception Care Project that's being piloted in 4 clinics in Marion County. We also have the Coles Caring for Our Kids program, which works to improve access to high-quality childcare in high-risk zip codes for infant mortality. They also provide safe sleep materials and train childcare staff to be safe sleep educators for families at increased risk for sleep-related death. And what's really important is these childcare providers actually model the safe sleep practices in childcare and help the families do that at home. Their goals are to improve the progress of childcare centers towards national quality accreditation and increase the number of parents reporting safe sleep practices by 30% over 2 years. We also have one of Dr. Turman's new programs, the Grassroots Maternal and Child Health Leadership Training Program. This program focuses on a key concept. If we want to improve infant mortality rates, we really need to bring to the table the communities and members most affected and develop leaders from within to promote meaningful change. Or simply put, to improve infant mortality rates, ask the women. And so this team is training and mentoring women within high-risk infant mortality zip codes to help their neighborhoods improve pregnancy and birth outcomes. These leaders then work to understand the root causes and build a community where every pregnancy and baby has the opportunity to thrive. As we wrap up, it's important to remember that to achieve health equity, we must have sustained societal action to remove obstacles to health and increase opportunities to be healthy for everyone, focusing particularly on those who face the greatest social obstacles and have worse health. Because this is our call to action. If the Black infant mortality rate was the same as the white infant mortality rate in 2017, there would be 101 more 1-year-olds alive in Indiana. And that is certainly something we should all be working together to support. So I wanted to give a quick thanks to everybody who helped me with this presentation. I feel like I would be remiss if I didn't mention the problem that goes hand in hand with infant mortality, which is maternal mortality. Maternal mortality is defined as the death of a woman related to pregnancy or childbirth up to a year after the end of her pregnancy. The U.S. is one of only 13 countries in the world where the rate of maternal mortality is now worse than it was 25 years ago. Each year, an estimated 700 maternal deaths occur in the U.S., and Black mothers die at a rate 3 to 4 times higher than white mothers. This picture is from the Blanket Change campaign, where March of Dimes laid 700 receiving blankets on the National Mall to raise awareness of this equally important issue last fall. So with that, I will say thank you. Definitely willing to take questions. Again, I don't know that I have all the answers to everything, but I have a lot of other infant mortality experts in the room who may be able to help me as well. And thank you guys so much. Yeah.
I talk to a lot of NICU parents and parents post-discharge from the hospital. And when I talk to the moms where there's a dad that's involved, and I ask them if dad attended Safe Sleep, hardly any of them have.
Yeah.
And there are a lot of dads and baby dads that provide childcare for their newborns.
Absolutely.
And they're not getting the Safe Sleep education.
Yes.
And I cover the whole state of Indiana.
And what group do you work with?
I'm the pediatric case manager at MD Wise.
Wonderful. Okay. Well, I actually have some friends who may be able to address a little bit of this, but one of the work groups in Marion County right now is actually focusing on education for dads for safe sleep through the FEMUR Community Action Team through Marion County. And I think that's a wonderful point. The whole idea behind safe sleep is that we can't just focus on educating the moms, which is often the captive audience during our hospital stay, and then also during well child visits. It's usually the mom that brings the baby in, but we have to make sure everybody in the community is educated, including dads, including child care providers, including grandparents, because grandparents are a big culprit for placing the baby in an unsafe sleep position. And so this really requires a community approach and everyone knowing this information. So thank you so much for that observation. I think a lot of us in the room would agree with that.
So,
Hi.
Hello, good afternoon. Thank you, Dr. Scott, first and foremost, for your presentation. It was very well informed. And hello to everyone that is here in attendance. My name is Felicia Haney, and thank you so much for the First Lady who spoke. We wear dual hats in our field of work, and we have a passion to do so. I'm also a part of FEMUR CAT for the Community Action Team, and there are 4 subgroups. If you are interested, we are always looking to partner and extend the knowledge for safe sleep best practices for the fatherhood, pregnant parenting moms, youth, and also grandparents. And then I would also like to say that I am the project manager for Indianapolis Healthy Start. We are a federally funded program. We've been connected with HRSA for over 21 years, and we work in the zip codes that you had a slide on that had the top infant mortality rates in the 6 zip codes in Marion County. We are in those zip codes. So we work with the pregnant and parenting moms up until when that mom finds out she's pregnant, up until that child turns 18 months. And there's 11 zip codes in Marion County now, and looking at the data, unfortunately, but fortunately, the numbers have increased, but those are now the zip codes that we're focusing in on. We have the case managers. We also have bilingual health educators and case managers to work in that area as well, too. And I know that we're all here because we are passionate about helping the babies, but like Dr. Scott said, it's not just the babies, it's not just the moms. We really have to go into and work in the entire household. There's so much different issues going on in the home than just, the prenatal care. Yes, that's very important, but there's a lot of social determinants of health issues arising, a lot of different concerns. And then we also want to make sure we're working in the community, but also keep in mind those who have recently been released from prison, those women who are incarcerated and who were pregnant. They need just as much help as everyone else. So I just wanted to say thank you again. I think there's a lot of resources and opportunities for partnerships here, and I'm definitely open to it. So thank you.
Thank you so much for sharing that.
David Weaver, Genetics.
Hi.
You didn't mention funding. Do you want to talk about that?
Well, that's a big question, right? I think that there are opportunities for, I guess, say specifically about funding for research, or funding for projects.
Support all these programs that you mentioned, which sounds very wonderful, but no money, no program.
That's the hard part, right? I think the good thing right now in Indiana is there is such a focus on this that there is more money available than there has been in the past, but you're right, I think that's always a challenge. And then I think the thing too is to figure out which of these programs is truly impactful, and then making sure we're not just trying lots of different things, but focusing on the things that have shown success as well.
Good afternoon. I'm Yvonne Beasley. I'm Director of Maternal and Child Health at the Marion County Public Health Department, and also the Project Director for Indianapolis Healthy Start. And as we think about funding for other Healthy Start projects, there are 100 Healthy Start projects that are now funded by HRSA. There are now 5 Healthy Start projects in Indiana. 4 were added on during the last funding period, and our new 5-year cycle started April 1st, and it will go through March 31st of 2024. So initially, there were 2 projects here in Indiana, the one here in Indianapolis and the one at Northwest Indiana, which was one of the first Healthy Start projects. We were very heartbroken because Northwest Indiana was not funded during this round. But we do have the other 4 projects that are new. One is in Linton, and that's rural health. The others are in Columbus, Indiana, in Terre Haute, Indiana, and in Fort Wayne, Indiana. So there has been some additional support federally for Healthy Starts and making sure that every baby gets a Healthy Start. Thank you.
Thank you, Yvonne. No other questions? Oh, that's over there.
I'm just curious whether or not you found a correlation in the relationship of the parent. I know you're looking at the whole family situation, but does partnered mothering help? I mean, in other words, does that change the outcome at any rate? I didn't see anything regarding that.
Yeah, and I didn't include anything in this. I certainly know there's been really nice. Has anyone at the breastfeeding conference this year for the State Department of Health? I know you were, Nolan. So they actually presented some really interesting studies out of Kenya where they looked at the mother being mothered while she was mothering her infant and showed really improved outcomes in terms of, birth weight and how the baby thrived in the first years of life. I don't know that that's been done here in the United States. Does anyone know? Looking for my friends who read a lot of articles too. But I think that's a really good point. It's something that would be interesting to look at for sure. Because we know that the more support a mom has during her pregnancy and the whole family has after delivery, that is so crucial in terms of, breastfeeding, doing safe sleep practices, and helping that baby developmentally thrive as well.
Has anybody looked into disparities in like the utilization of and engagement with healthcare? Because while the access rate, the disparities in access might be closing, I know that African Americans in particular tend to have more distrust in healthcare professions. So has anyone looked at not just improving the access, but also increasing use and engagement?
I don't know that has been looked at in terms of not just, I know that they've looked at access and shown that there still is a disparity even with equal access, but I don't know if anyone's looked specifically at that. I think what you're getting is more that trust piece, and from that, and I think that's where a lot of the work around the doulas projects that have been done in other states as well, to really have the mom have somebody that she feels comfortable with, that she knows very, very well, come in and be an advocate for her in the hospital and in healthcare settings. So I think that's the idea behind some of that important work as well.
Thanks so much. Are any of these projects or are there other projects targeting implicit bias?
So none of these specific projects are targeting implicit bias, but I think March of Dimes is working on some. Where's Gina? Hi. They are, right? Yes.
They are. Hi, Gina Siley with March of Dimes. We are actually rolling out a new implicit bias training for providers. We're going to be at the NACHO conference in July, and we're actually going to be training all of the providers at that conference. That'll be our first training opportunity, with 2 more happening later this year as well. The goal is to then be able to roll this out statewide, as well as at other national conferences as well. I do also want to add that Indiana is also now an AIM state, so the Alliance for the Innovation in Maternal Health, and that provides the Indiana State Department of Health access to a bunch of bundles that we can now roll out to various hospital systems. So we just had the kickoff, I think, like 2 weeks ago at the Ritz Charles, and the first bundle they'll be rolling out is obstetric hemorrhage, but there is a disparities bundle within AIM that I'm sure will be coming, and that's something that I'm sure the State Department of Health will be pushing out through the Hospital Association and through other healthcare systems.
I'm curious about the disparities in child care practices during the first year of life.
You guys, I don't know the answer to that. Do you guys think at my friends who do a lot of work with childcare? We're going to hand the microphone to Dr. Sklansky. This is my favorite question and answer session because I know a lot of people in the audience, and I'm just passing things off to people. So it's working out really well for me. Thanks, Dr. Sklansky.
So are you talking about the access to safe and affordable childcare, or are you just talking about parenting practices? Rim, yeah. Yeah, I don't know if it has, how close of tie it has with the infant mortality rates. We know that everybody, including probably everybody here, has trouble getting safe, affordable infant childcare. And one of the things that we're doing is working through the Coles Cares for Our Kids grant in the high-risk zip codes in Marion County, specifically to look at child care settings and encourage safe, affordable infant child care. So we work with them to go on the Paths to Quality, which is Indiana's quality rating system. So you actually get paid more as a child care provider on the federal voucher system if you go up that path to quality. And as you go up the path to quality, we know that there's many more safety and other practices that are used. And our hypothesis is that as we can, you know, as Emily showed, especially last year, in fact, our deaths from unsafe sleep-related deaths as almost 5 times higher than whites now in Indiana. And so one of the things we know is that we need to do a much better job of role modeling and reaching out to parents. And certainly by law, child cares are required to do safe sleep practices. And what we're trying to do is to train and encourage the providers to be better able to talk with parents about safe sleep, to link them to resources so that everybody in those high-risk communities have safe, affordable childcare, but also a link to resources for their infants.
I think we're going to finish up with one more question from one of our broadcast locations.
So can you share a little bit more about the Harvard implicit bias test?
Yes.
And how there are different options and just a bit of sharing.
So has anyone else done the Harvard? I'm sure several of you guys have done it. So it is a really fascinating tool. It's available for free online. If you just Google Harvard implicit bias, it'll come up. I don't remember the exact web link. And it allows you to, it's not just for race, they have it for gender, they have it for age, they have it for weight. And basically what it does is it tracks your time for how long it takes you to identify a non-majority group with a positive or negative characteristic. So that is kind of how they are testing your implicit bias, is by how fast it takes you to get a to match the picture of somebody in a non-majority group with a positive or negative characteristic. And so I would really encourage anybody to take it. I did it a couple years ago through training with the American Academy of Pediatrics, and just found it personally very helpful for me, but also helpful to guide discussions within our group, because it certainly opens up your eyes to your own implicit bias, which I think honestly at first blush a lot of people are like, well, I don't have that, but we all do, and that's okay. It's not, that's the way that things are right now. That's the way. It's not anything that's wrong to have that. It's just that you have to recognize it.
Thank you, Dr. Scott, for coming and speaking with us today. One quick announcement. You'll notice that the trash cans outside are very small and the boxes are a little large. You may leave the boxes on the table, or if you still have food in them, take them with you. And we will see you back in September.